Hello, I am Monimita Sarkar, the founder of Unmukt, the Senior Hub. Today we present the webinar jointly hosted by the Association of Senior Living India, ASLI, and Unmukt Cares on bringing medical care to your doorstep. ASLI is a national membership organization of developers, caregivers, home care providers, service providers, retailers of lifestyle and technology products and services. Home health care is a medical care provided in a patient's home. Home health care can include broad care given by skilled medical professionals, including skilled nursing, physical therapy, occupational therapy, and speech therapy. Home health care can also include skilled non medical care or assistance with daily living. It is usually less expensive and more convenient than a hospital. It certainly helps older adults live in their home for as long as possible, even with an illness or injury. Home care services can help someone who's aging and needs assistance to live independently. Home care can be the key to achieving enhanced quality of life for seniors because of increased independence. It can ease management of an ongoing medical condition. It can help avoid unnecessary hospitalization and aid in the recovery period by being in the familiar environment of their homes, all through caregiving in the comfort of their homes. And that helps a lot. And I am delighted to present our panelists today, Neha Sinha, co-founder and CEO of Epoch Assisted Living, Vaibhav Tiwari, Chief Operating Officer, Portia Medical, Dr. Rana Mukherjee, Founder Director, Care Continuum, Raja Gopal, co-founder and CEO, Kites Senior Care, and Dr. Manpreet Gehlon, Chief Customer Relationships, Emoha Elder Care. And my first question, Vaibhav, is to you. Being the largest player in the home healthcare segment in the country, can you briefly tell us about the journey and what has been the top 3 or 4 learnings that you have?
So, as I think many of us are aware that home care has been primarily a domain of unorganized segment for a fairly long period. It's a fairly well-established practice worldwide. There are quite a few companies which have been doing it in a very large scale and fairly sophisticated for a long time. India, of course, had mostly unorganized this service. And then, of course, around 6.5, 7 years back, Portia and few other companies started out in this space and tried to organize this segment into basically taking the hospital level care to the patient homes. So the whole idea behind Portia was that for tertiary care, hospitals are there. For every other care, can we come to your homes or to your offices and support you with all the healthcare needs which you have. There's a whole premise with which we started, and of course, in last 6.5 years have reached out to 22 cities with close to 1.5 lakh visits a month to patient homes, with close to 4,000 people who are going to patient homes and supporting them, and support the complete range of healthcare services, what we define, and which probably is the 4 pillars of home care as well. That is post-operative care, elder care, primary care, and chronic disease management. And of course, these 4 segments have significantly grown both from different home care providers perspective, as well as some of the specialist players who have come into each of these areas and built these verticals up to the next level of sophistication. So of course, the last 6.5, 7-year-old journey has been very enriching. I always say that for us, the good karma is very good actually, because we always end up supporting the patients in their the most needy times, and the blessings you get from them probably are the rewards for this work. And I'm sure my co-panelists will agree with that. So that's something apart from that, which is the good karma we generated. I think 3-4 things which have worked well. One is that this got established as an industry in itself and opened job opportunities for a fairly new segment which didn't exist earlier. So if you look at home care, like physiotherapy, for example, we were doing physiotherapy. Before that, physiotherapy was mostly done after a doctor's consult. So people will go to an orthopedic doctor, and then basis what he says, people go to physiotherapists. After we started home care and launched physiotherapy as an offering, a lot of people started going to physiotherapists first if they have some neck pain, back pain, or even like little bit severe pain, and see if they can become better. So from a physiotherapy perspective, it became a more of a B2C service post home care, being more organized, and more of like B2B2C. B2B2C it was earlier, doctor driven. Now it has also become consumer driven. Nursing attendant is a service which we launched, basically the caregivers actually, right? The what we call as GDA and bedside assistants. That as a career came into a lot more forefront. That didn't exist as a career before. People were leveraging their mates or any other support functions at home to provide that kind of thing. But after home care became sizable and became organized, that became a career for many people. I mean, we have so many of those stories which are there where people have joined us, have been with us, supporting patients, have become team leaders, one or two of them become managers. So those kind of things, that segment of people who are seeking jobs got a career for themselves actually. So it became like a well-respected career for those people. I would say that's another big positive which has come out of it. Third is from patient's perspective, the elder care part of it, the chronic disease part of it. I think a lot of those things also got a lot more fillip in last 6-7 years. I mean, post-operative care was being done in some form or shape before that. But elder care is something which has become very sizable in last 6 to 7 years. I mean, many of us are looking at that segment and seeing what we can do differently for all of them. So that segment got a lot more importance in terms of how they're being taken care of from a healthcare perspective. So I would say these are 3 or 4 key things which have happened. Apart from us, of course, this becoming an industry, and some bit of that we saw during this COVID crisis. I mean, I'll just take 1 minute to talk about it. Is that before that, home care was like an add-on from a healthcare perspective. We are like not the front and central player in the healthcare. But in this COVID scenario, the home healthcare became very critical because government approved, saying that, okay, COVID patients who are early stage can be treated at home, right? Teleconsulting started picking up now. And even government notification, if you see, when they started opening lockdowns, the general duty assistance for elderly was taken as a category which was allowed from the lockdown actually. So home care, in all government discussions, in all healthcare discussions, home care became very critical because in this period, people saw the real value of what home care can bring in this crisis situation. So I would say in last 6.5, 7 years, there's one major shift has happened where this industry has become an industry now, and of course has got a lot more prominence than what we had a few years back.
Yes, so you would definitely say that it's become much more organized. It's now from the unorganized sector, it's slowly moving it into the organized sector. So thanks for sharing some of those, and particularly how it's evolving even in today, where government is taking, calling out, for instance, aware that, the elders need this kind of support. My next question is to Dr. Rana Mukherjee. So what are the different types of healthcare, home healthcare, if you can sort of elaborate on that, and which are some of the services that Care Continuum offers? Please unmute yourself.
Yeah, thanks, Mani. You see, I'll kind of step back a few years. What was home care before it became organized, before people came into it as an industry? If you look back, it used to be provided basically by the general physicians, the family doctors, aided by some of their assistants whom they sent to do a dressing or to do an injection. And that was what home care was all about. Now, then the family doctors stopped making house visits. Once they stopped making house visits, this entire care was left in the hands of these semi-trained people who had been promoted from being household helps to being a medical assistant. And that was all that was available. And that was all that people got used to, the ayahs. Now, when the organized players moved in, it is only then that there is a semblance of medical inputs that is provided by these companies. And they have got back a semblance of order into this scenario. Now, you asked about how many types of home care. If we, going back to what Vaibhav said, there are two ends. One is the post-hospitalization care, and then there is the elderly care, and then there are segments in between. So home care actually looks after two groups of patients: people who have been hospitalized in the past and require post-hospitalization care, and people who are elderly and usually on their own, requiring some kind of support. So these two comprise of the entire pool of patients who require home care. There is a third segment which kind of intersects both these two, and that is long-term care. Long-term care meaning things like stroke care or dementia care, or even long-term palliative care. So these are the ones that are specialized cares which come in between. So for post-hospitalization care, you have a general care that is provided, and then you have specific cares. Like people would now say that somebody with a joint replacement care is something that is a composite care and can be provided by this team, which has maybe a physiotherapist, occupational therapist, we have a dietitian. So a multidisciplinary team providing inputs as and when required. Similarly, Parkinson's care, then dementia, Alzheimer's care. These are all part of that spectrum. And in the elderly care, there are three types, generally, quite like the residential care types. One is independent living, the other is assisted living, and the third is continuous care. So for people who are in the independent living area, for them it is only assistance when they require it. They generally don't take kindly to being monitored or supervised. So they choose when to take the care. The assisted living category is where there is a requirement, but it is not necessarily a continuous requirement. This is the place where monitoring, supervision, all these activities are of greatest value. And then there are the continuous care, like kind of long-term stroke care, dementia care, and palliative care, long-term palliative care, who say a long-term COPD patient who is kind of borderline, needs hospitalization. You can bring down hospitalization by taking care of them long-term. So in terms of slicing and dicing, I think these are the categories that I would say.
Okay, thank you. And Dr. Manreet, if you can tell us which are the services which are included under EMOHA's at-home services, and when were these launched?
Thank you, Monimita. Monimita, EMOHA is basically an organization that provides services to the elders only. And we provide comprehensive care services to elders, which can be basically divided into 5 buckets, which would include healthcare, emergency, then safety, then convenience, engagement. So our motto is to ensure every elder to be absolutely safe, secure, and continue living in their own house till the time it is possible for them. We have special focus on age-related conditions, like all my co-panelists have also mentioned: stroke rehabilitation, then dementia care, Alzheimer's care, Parkinson's care, because these are the main conditions which affect the elderly at that stage. So we do look after such kind of elders with the help of trained clinical staff and accurate monitoring, which is backed by the technology. And our range of services include preventive health plans for healthy elders. And going forward, we provide emergency support. I mean, the range is from providing preventive care plans to providing emergency in case of any kind of crisis. And we proactively manage these emergencies with the help of ex-defense personnel and the paramedics. And also provide, in case the health deteriorates a little, then we provide hospital companion for an elder in case elder is staying all by himself during hospitalization. And further on, step down care when required at home post hospitalization is again what we do. So till the elder stabilizes and reaches a stage wherein preventive care can be continued. So we at Emoha have the administrative capabilities to monitor and interject in elders' life at the right time. So this is how we say that we do provide envelope of care for an elder, or we do provide continuity of care. How do we provide that? Because the members, the elders who become our members, most of them are healthy, some of them are unhealthy, but most of them are healthy. Then as few of them start deteriorating in health, so that's when they require hospitalization. So we are their companions in hospital as well. Then post-hospitalization, again, we are their companions till the time they don't recuperate and again come back to stage 1, wherein a preventive care plan can continue. So these are the kind of services that we provide.
Thank you, Dr. Manpreet. And that's interesting. And because I know that you also provide active aging services, which is great. And you know that's the care continuum, I guess. Neha, and you know, with the advent of formal home healthcare segment, how does the customer evaluate the scope and benefit offered by the formal providers vis-a-vis the non-formal segment, right? Which has been around for so long. We've all known the hospital ayah, etc. For that you could just get, who came home and looked after a parent or somebody who was sick. And how should a consumer truly evaluate quality versus cost and versus reliability?
Right, Monimita. So see, Weber was mentioning earlier, home healthcare is a very, very organized and a structured, very well-defined industry, especially in the global context. So home care providers are, in fact, people who are trained and licensed to be giving out these services. Why it needs to be that way is because elder care is a specialized offering, which is, now slowly getting recognized in India. So informal providers are not really trained or reliable to be able to give out these personalized or specialized care, which is required for an elder at home. So if there's an elderly at home, obviously, and they're needing healthcare services, they have a certain requirement. So it's not general care, but it is, specialized care. So to give you an example, transferring an elderly from the bed to the wheelchair is not really an easy skill. And there is a lot of training which goes in so that when you do it at ease, you don't hurt them, you don't make a skin tear and so on. So, preventive skin care or wound care, or even small things like the importance of, hydration in an elderly and so on. So these are things which are not really general, which I don't think, somebody like a hospital ayah or a domestic didi would, even with the best of intentions, will be able to carry out from a preventive perspective. It's great to be an assistant for someone who just needs a prompt, or who doesn't really need continuous monitoring, like Dr. Mukherjee was saying, especially assistive and continuous care. So one really has to evaluate the quality of care, and I would say in turn the quality of life which one provides to an elderly who is in need of home care. And today, as we see, the home healthcare industry in India is becoming more and more process-based. There are protocols which are followed for every single thing. People are trained, and one can truly rely on them for continuity of services. Elderly do not want to see a new person every day. So what we are looking for is reliability. We can't give it through a person, then you at least give it through a service provider who takes the responsibility of transferring the care plan and make sure that there is a solid handover. So the consumer, the elderly who is getting the services in turn is not, is the one paying the price.
Neha, you just mentioned licensed providers. So can you tell us a little more? I mean, who is the licensing authority or body? Is there something like that?
I think,
or are these trained nurses, etc.?
Yeah, so trained nurses have their own licenses. They are registered nurses who, who even for medication management or for giving out those, things like insulin or any other kind of course, skilled nursing services, they need to be given by licensed providers. But certification for general duty assistants or care assistants, there are certifications given out by the government as well. And I think, my co-panelists would be able to give you a clearer picture on what exactly are the other licensing authorities.
Yeah, maybe we can come to that soon, in one of the later questions. Raj, I have a question for you. What do you think are the merits of home care over institutional care?
Thank you, Monimita and ASLI, for this opportunity. Home care is very much in its nascent stage right now, and there's a huge opportunity. Institutional care, on the other hand, is even more newer in concept in India, while it's pretty prevalent in the developed countries. So what I mean by institutional care is something that is sandwiched between your traditional hospital care and the home care. And developed countries actually are extensively practicing this. As Dr. Rana Mukherjee mentioned, there are various settings in which people can be taken care, especially elderly folks, which could be a transition care center, or otherwise called as nursing homes, or your palliative care centers, or even for that matter, memory care centers. So you do have specialized centers where people can be taken care of rather than at their home setting. Now, it's a very important situation that we are in right now, because COVID has actually, pushed a lot of work spaces into the homes. And so therefore, this particular home care versus institutional care debate becomes very relevant at this point in time, because every couple at home largely are working couple. So their home space now is also included by office space. And so they have children, they have to take care of their family affair, and they also have elderly people to be taken care at home. So at this point in time, I think institutional care actually steps in, and it's a very good alternative for a home care as a solution. I'll give you some minutes of the institutional care that is happening. First of all, I think institutional care is a specialized area where you have resources that are wholly and exclusively trained to manage such situations, and to have, which is led by basically a physician, monitored by a specialist in their own verticals. It could be nursing, it could be therapy specialist, it could be your social worker, so on and so forth. We actually run 2 of such facility with about 70 beds in Bangalore, which is about 5 to 6 months young in its own evolving space. Okay, so you actually get a very better monitoring and clinical outcome in these spaces, and there is a wholesome and efficient recovery for the patients in these locations. And by the way, I very firmly believe that these spaces have to be a neighborhood space, for the simple reason children can visit, the family members and relatives can actually visit them whenever they want. In fact, we call this concept as, comfort of home and care of a hospital, and that's the amalgamation that we are looking at. And therefore, with these changing times, I think institutional care is going to play a very important role, which will certainly supplement the home care, because obviously people staying at home is very, very important. Getting back into their home environment is very important. But that period post-hospitalization, or when they actually require very aggressive care, I think it's very important to move them to a specialistic care center and then move them back into their home care environment. And by the way, it's very easy.
Are you talking about transitional care?
Transition care is one aspect of the institutional care. In fact, the memory care is also part of the institutional care. Palliative care is part of the institutional care, and so on and so forth. You have a plethora, as Dr. Rana was mentioning, we have a plethora of environment which provides this institutional care. And most importantly, Moni, I think people need to know that post-hospitalization, especially for a surgical intervention, beyond 2-3 days, there is no really relevant for them in the hospital environment. They basically can move out of that environment, okay? But for an effective recovery and early recovery, it is important that they are monitored very closely in a multidisciplinary environment, which I think an institutional care can provide better than a home care environment. So I think the way it is going to work is institutional care will come in sandwiched between the home care and the traditional hospital care.
Yeah, okay, thank you. But one of the things is, of course, the specialized care. And I wanted to the next question is for Vaibhav, especially when we're talking about specialized care for oncology, for chronic kidney disease, for various types of ortho care. So what are these different things, specialized care that you're offering, that Portia offers, Vaibhav? Can you elaborate on that a little bit? Please unmute yourself.
Sorry. So a few things, of course, which as I was saying, the services became more organized and home care became an industry. The doctors also start looking at this as a very viable option to basically move their patients in our care actually. So few services which are fairly specialized, which we launched in last couple of years. One is what we call critical care. So critical care is basically ICU care at home. So we work with the intensivist and the other doctors and look at how the patients can move from the ICUs to their homes, either basically in their recovery phase or in basically end of life. So both of those things can be managed at home with a full ICU setup, with the nurses, of course, specialized nurses being there, and a doctor being available, monitoring everything using point of care devices, and making sure the patient is taken care of the way the patient will get taken care of in an ICU. So, and of course, if you move home, you are probably better chances of recovery because you are with your loved ones. So the hospital level ICU care is what we've been providing at home, and have been offering it across all the cities for last year and a half to 2 years with very good results. In fact, some of the recovery rates of the patients whom we have serviced at home from an ICU perspective, their readmission rates in the hospitals are lower than the published US standards of readmissions actually. So basically the way to judge home care is that is the readmission rate in a particular, for a particular patient, is a percentage is coming down or not. And the patients who have been in our care at home from an ICU management perspective, their readmission rates are better than, or if put it the other way, lower than what readmissions you see in the US markets actually. So that's something which has been very positive. And of course, that has been a good success and a very good value add for the patients. We launched few more services in line with that, what we call oncology services at home. And that has become a big necessity now with the COVID scenario, because your cancer patients are probably one of the most vulnerable to catch the infections if they are going to the hospitals. And hospitals have not been that much available in last couple of months due to COVID scare. And a lot more patients are looking at can the onco care be done for them at home? Can we do chemotherapy for them at home? So in fact, last couple of months, we have partnered with quite a few companies, pharmaceutical companies, as well as hospitals, where we are looking at doing chemotherapy at home for the patients. Have started for quite a few patients, are doing multiple sessions for them, which we believe is again something here to stay. So oncology care, chemotherapy at home especially is something which we are doing now. The third one, which has picked up quite well, is the whole diabetes management. We launched this offering around a year and a half back, where we work with patients and help them monitor and manage their diabetes under the permissible levels, and look at how they move from being severe diabetic to medium to mild diabetic and things like that, with very good results. We are probably managing close to 40,000 patients right now whom we have acquired in last year or so, and are helping them to basically manage their diabetes. We see tremendous value over there because India is the diabetes capital of the world. And again, in the COVID scenario, that becomes a lot more critical, because we know that people who have chronic diseases are a lot more vulnerable to catch COVID. So now the awareness in this scenario to basically take care of their diabetes again becomes a lot more important. That's another area which we believe has tremendous potential to build solutions in, and a lot of value can be offered to the patients in the comforts of their homes actually. That's again something.
There's one question which we'll take all the questions at the end, but there's one question that's just come up which is so relevant, so I'm going to break the thing and take that question. It's ICU care. Isn't it very difficult business in terms of legal implications and revenue versus expense perspective? And that's from Nanki Singh. And it was so relevant to the discussion, I thought I would just, so it's revenue versus expense and the legal implications of offering it at home. Vaibhav, anything on that?
So revenue versus expense, I would say that, I would just give a perspective that if you do a ICU with a good hospital, you'll probably spend 20 to 30,000 rupees a day. If you do at home, you'll probably spend anywhere between 9 to 12,000 rupees a day. So from a patient perspective, it works very well. From service provider perspective also, how you package it, how you work with the patient is no less revenue or difference with profitability compared to like a regular nursing or things like that. So of course it has to be packaged the right way, where patient gets the full value of moving from a hospital to home, and of course service provider also gets value for providing that. So that is there. The liability, whether medical, legal or otherwise, any home care which we do, the medical legal liability of the home treatment lies with the service provider. Medical legal liability of the treatment plan lies with the doctor, actually treating doctor. And that holds true for regular home care as well as for any other service which you provide at home. So any of the treatment plan, the prescription which is given, the liability is with the doctor, and the treatment basis that if you have done or not done correctly is liabilities with us.
And in this case, the doctor is quite often in the hospital, right?
Yes, doctor in the hospital and doctor is quite involved in this actually, because this particular service is also moving to patient. Patient is moving to homes under doctor supervision. So the treating doctor is involved, the senior doctor from our side who's involved, because who's taking the handover from the main treating doctor and then taking patient home. So the process is a lot more complex, but process is a lot more involved as well actually.
Okay, thanks. And I think now we really need to come to some of the COVID related questions, because everybody somehow, we all come back to that. So Raj, a question for you, COVID-19 challenges, and how has home healthcare ramped up, you think, to manage the new requirement of this?
Thank you, Moni. See, today, from a COVID-19 perspective, I think the biggest challenge for some of the home care players or all of the home care players has been mobilizing the resources, especially with the lockdown of interstate movement. I think once the lockdown was announced, people who were in the city were fine to continue, and they were counseled and they are continuing their services. But, larger portion of these resources do come from outside the state. And these people constantly travel between their home state and us. And therefore, every city has got its own challenge because of the COVID-19 lockdown. And also another thing that's come up is the fear of the migrant workforce that you're seeing actually right now. Many of the migrant workforce wanting to go back to their hometown. And that's causing a very big challenge. In fact, recently, about 2 days back, I was in a teleconference with the Government of Karnataka Labour Department, and the IAS officer in charge of the department spoke very elaborately on this. And the biggest challenge for any government, I guess, at this point in time is how do you allay the fear of migrant workers or the migrant workforce and try to entice them to come back. And so, therefore, this COVID-19 is a challenge to all the home care players, because your home care foundation is based on the nurses and nursing attendants as a foundation, while all the others actually top up and work around them at this point in time. One of the things that we have done is a bit ahead of time, we realized that this is going to be probably a long-term problem. So we, along with a foundation called NIVA Foundation in Bangalore, along with Times of India, we actually launched a skilling program for people who actually have lost their job, especially people who have been working at the lower end of the profile, which is like your housekeeping folks or security, so on and so forth. We've actually launched a skilling program where we said we will take them, train them over a period of a couple of weeks, provide them a structured training program, and then probably once they get out of it successfully, we are able to provide them opportunity to place them. So we are actually running a trial right now, and I'm happy to share with you, just in the matter of about 10 days, we have received over about 80 odd applications, and we have actually formulated the first batch, which will go live. I think, so the point here is, I think we need to start looking at it very innovatively to see how we tap into this situation, which is going to be probably be there for some more time to come before the issues get back to probably to some extent to the near of normal.
Okay.
The positive thing that I want to share with you during this COVID-19 is the societies, especially where you have the cities, where the urban conglomerates, where you have apartments and complexes, they have recognized the importance of home health. And this is one of the services that they have not prohibited from entering into their complex. And that's something has been a fantastic reception from the public. So that shows the kind of acceptance of home health care at this point in time.
Thank you, Raj. And next question is for Dr. Rana Mukherjee. This is linked, of course. When we look at COVID-19 scenario for home healthcare providers, and how is this going to change going forward, particularly knowing that the virus is possibly here to stay? Please unmute. Yeah.
Yep. Let me say something, Moni. When, as home care providers, we were faced with this problem initially, you see, there are a lot of peripheral problems, but centrally, the problem is that the patient should not get infected from our service providers, and our service providers should not get infected from the patient. It works both ways. So what we initiated was we spoke very early to the families and to the service providers, and we made them understand that the best scenario would be that the service provider, the bedside service provider, stays on in the household, becomes part of the household, thereby ensuring that they are not getting exposed to infection. Now, initially, we had all thought that it would be for maybe a month and a half. Now, it seems to be carrying on and on and on. So that is by judicious counseling and doing logistics properly, we have been able to manage without causing any concern to the families. However, the time is coming when these people cannot stay on in one place. So there will be a need for getting new service providers into the homes. And there will be patients coming out from the hospitals. Those who are surgical patients will have COVID testing done, but medical patients may or may not have COVID testing done. There will be family members of post-hospitalization patients who are moving out and in a restricted manner, but still. So there is an environment where there might be a possibility of infection coming through. And as you said very correctly, we all know that COVID is here to stay. It's not going to go away. So in that case, the next best thing is to try and create a structure where there is enough understanding for both the family members as well as the service providers of the realities of the situation, and a kind of undertaking that there are no guarantees. We have already started sending out addendums to the contracts that we have for providing service, which states that we are doing these things as a precaution. However, this is the reality about the infection, the virus, and therefore you have to understand that there are no guarantees that we have. We will try our best, but we will not be able to say that, and the government has yet not started free or, easy access to COVID testing because of lack of kits. So when that happens, maybe we could test each and every service provider. But for the time being, we are having to go by these undertakings. Looking forward still, when local transport picks up, and as Rajagopal mentioned, that a lot of these service providers are from outside the base. It could be other states, it could be other suburbs, etc. When they start commuting, you will have very little knowledge of where they have been and who they have been exposed to. So paradoxically, I think the first month and a half, we've been struggling, but it's been manageable. Looking forward over the next 3 or 4 months is really going to be a nightmare.
It is. It's going to be very hard because they're really big, and there are asymptomatic people going around, right?
Yeah, yeah.
So if somebody had symptoms, you could always say, don't come to work or stay away or something. But when you're asymptomatic, there is very little we can do unless there's testing. Anyway, the next question, Manpreet, the fallout of COVID-19, particularly for the aging population, many have put off surgeries or other medical interventions, and there are long delays which have taken place due to basically non-availability, and nobody goes to hospitals, right, of medical facilities. So and this will create a high demand for acute care. How do you think this is going to impact home health care providers? Because this acute care is going to show up suddenly when things open, and many people haven't been able to access medication. I mean, if a diabetes patient hasn't had medication, all the parameters will be off.
Yes, Manimata, you're absolutely right. Since the media, I think it's more of a media hype, media publicity regarding elderly being the most affected lot by COVID-19. Now, even when the hospitals are open, elderly would never want to go. They are still delaying, even if they are unwell. In fact, 3 days back, one of our elderly got very, very sick. Because the couple was waiting that we'll wait for another 2-3 days, maybe we settle down. But then finally the blood sugar levels dropped to such a level that it became an emergency and he had to be moved to the hospital. So you're absolutely correct when you say that there is going to be a delay of elderly going into the hospitals. So as a home health provider or as an elder care provider, our primary concern should be to take care of their pain, to ease their pain and improve the quality of life, how much ever we can, of an elder at home till the time everything is normal, which doesn't appear to be very close by. And also, since there is a need of a supervised care at home by the trained caregivers, giving such a scenario where the conditions may deteriorate. So we require a little more specialized care for them. So the demand for services like physiotherapy, specialized caregiving, it all increases. And we at AMOHA, we definitely endeavor to maintain a status quo and prevent further deterioration of health of any elder. In fact, going forward, looking at the whole scenario, it may change completely, wherein an elder or any patient would like to get hospitalized just for the shortest period of time, just for the surgical intervention, then try to come back as soon as possible and continue with a step-down care at home under virtual supervision of a clinical professional or things like that, because nobody would like to stay in the hospital for a longer period of time to recuperate. So positively, the specialized caregivers required will be much higher. So at this point in time, I feel that as one of my co-panelists was mentioning, that skilling of the caregivers is the right indication. We would require many, many more skilled and specialized nurses, etc., going forward to take care.
Thank you, Manri. Vaibhav, how do you see this recruitment and retention of home health care, caregivers happening, and what are providers doing now to recruit, especially because there is likely going to be a pent-up demand which is going to come up. It's going to be, possibly much higher than, what has been anticipated.
Yeah, so I think there are two parts to it. One is that people who are there right now, they have to be retained probably the most ideal way. That becomes very, very critical. And I think as Dr. Rana was talking about, those people who are in patients' homes, they have to be taken care of. They have to be educated on COVID. They have to be if they're staying in hostels or wherever they're staying, how do we make sure we are totally connected with them so they don't get scared and they run away? Because the whole migrant population moving back, and many of them also are the people who have moved from smaller cities and villages to bigger cities. So one thing is to basically work with them to make sure that not many of them are looking at going back mass scale. That's something which we have been able to manage so far quite well. And the whole point is basically talking to them and telling them, look, you're taken care of. Second, from recruitment perspective, I think a lot of recruitment is also has to happen locally. So of course, as we build the pipeline again with the NSDC partners who have trained people in smaller locations and they can start coming back to cities, that's something which is being worked on. A lot of partners have people under training or batches were under training. So my guess is maybe next 3 months or so, as the trains start again. We saw some trains starting today, so hopefully next 1 month trains will start more and more. Some people, of course, will start coming back. A lot of local recruitment becomes very important now, given that there will be the job losses in other areas. If we see, a lot of work from home is going to happen. Then whether it's Ola, Uber, a lot of other people who are working in restaurants and all will also probably look at alternate careers, because restaurants will open to much lesser capacity than what it is today. The scare of you going out and eating will remain for next 1 year. It's not going away. So a lot of other population which is working in similar fields will be available, like your saloons actually. All of those, and people when they came from smaller villages and smaller cities to big cities, they look at all of these as options. So we have to look at a lot of other people who are available in these big cities and maybe losing their jobs. So how we can reskill them and basically start recruiting people from there becomes very important actually. And there's another area we are looking at very actively now. So short term to mid term, look at people local recruitment, look at retention in a very, very strong manner. And of course, mid to long term, go back to the way we were running the programs with NSDC partners, because end of the day, this is one segment which will grow. And if I have other segments which are not growing or growing slower than this, then people will look at this as the next set of job actually. And I think as you said, or somebody else said, COVID is here to stay. We have to find ways to live with it. Like our Prime Minister said, COVID we have to live with. So people will find ways to live with it actually.
And actually Rajgopal also just mentioned that how they are hiring and trying to retrain people from the hospitality and other sectors,
Yes.
which are sort of allied in some way. You know, there's
Yes,
some basic
exactly.
skills which are saying, Neha, you are, you do dementia care, right? So can you tell us if dementia care can be provided at home, and how does home care for Alzheimer's or dementia differ from regular home care? And, what are the specialized skills that are required for this?
Sure. So, first we must, begin with the definition of what really is dementia care. So, it first begins with the ability to assess or stage dementia, understand the type of dementia, and then the entire clinical picture. First, we need to understand what the breakup of symptoms is, whether there are cognitive symptoms, behavioral challenges, psychotic symptoms, and so on. So basis this, one must come up with a personalized and holistic kind of a care plan, and this should be based on a person's past and current abilities. So dementia is a very complex condition. We all know that, I'm sure. So it's neurological in nature, but symptoms can be psychiatric, and plus it varies from person to person. So this needs specialized training for the person to first understand all these aspects and then figure out how the care has to be provided, because it is very, very unique to one single person. So if you look at any other physical conditions, you will see that symptoms are same. You can group them. There's a certain amount of homogeneity in how the disease progresses, what you see, how the person reacts, and so on. But dementia, unfortunately, is not like that. Especially when the elder concerned is most likely not even aware that they need help. So especially when it comes with helping with ADLs, which is activities of daily livings, this is, assisting with your showering, your changing clothes, grooming, eating, incontinence management, anything of those sort, they require training as well as experience, because this is the time when you see a lot of agitation. You might see challenging behavior kick in, and not many people know that antipsychotics are something which are prescribed very freely in India even today, although they have a black box warning on it in the US and other countries. So what is really helpful is how you continue to support them in these ADLs without the use of medication, how you understand the reason of their agitation. Yeah, certainly, I mean, home care is definitely an option if people are trained and have a full understanding of the disease progression. One of the most important aspects of dementia care is social or the engagement plan, which family members can really, really help with, because it's not really about looking at physical or medical health only. It also depends on interaction, your ability to understand and communicate when there is lack of language, and family members play a very, very critical role in it.
Thank you, Neha. We've got a lot of questions coming in, but I have two more which I have to do, and then we open it up. There are about 21 questions there, so there are lots of questions coming in. Dr. Rana, if you can quickly tell us, how is home healthcare financed, and does insurance companies cover the cost of this, particularly if care is prolonged over a period of time?
Well, very difficult to answer this quickly.
Yeah, and if it's not related to a hospital stages before it?
No, you see, that's a very important point. If there is a hospital stay before it, and the doctor at the time of discharge specifies that there will be some requirement of assistance at home, both by doctor visits or by nursing visits, then in most insurance structures, they would pay out for 45 days. However, in almost all of these insurance companies, they specify that the service has to be provided by a registered nurse. That is something very difficult. Even hospitals don't have enough registered nurses, so let alone home healthcare companies. So essentially, the home healthcare segment has been out of the insurance sector so far. Now, there is a very good reason to it. If you look at the insurance sector monitoring what happens in the hospitals, they have found that there's a lot of fudging going around. And the insurance companies are very scared. They're very worried that their payouts are very high, because a lot of, as I said, fudging goes on. Now that is in a hospital, in one location, and you can go and check what's going on. If it's for home care and it's scattered all over the city or all over the country, it's virtually impossible to monitor. And therefore, insurance companies would find it very difficult to come in with a viable scheme. I think the only solution is to collaborate with companies like us, the companies which can be monitored. And then the companies would be following protocols and steps that would ensure that the insurance companies can then work with them.
Yeah, because this is one thing that's covered in the West, right? The West is very organized, and you get, everything is paid for under insurance policies, of course. It's only here that if somebody needs extended care, that you may not get coverage for that.
The other reason is, I think there's not enough actuarial data in India which would prove that reduction of cost by home healthcare, reduction in readmissions, reduction in stay in hospitals for people who have been cared for supervised at home, can actually bring down the costs for the insurance companies. They need to know the benefits as well. They need to know that if I am paying out for this home care, I am going to save on hospitalization care. And once that data is available, and that is something that they can compute, then I think the insurance companies would be interested. I think IRDA, we have been approaching IRDA. At some point in time, we hope that this will come to fruition.
So it's possible. Vaibhav, would you say that if there is an accreditation process in place with guidelines, etc., which the providers follow, home care providers, then insurance might become easier if there's a protocol?
Yeah, so accreditation has got created. I think all the industry players got together a couple of years back and worked with QI to create the standards. And those standards became implemented around a year back or so. And a few players like ourselves, Healthcare at Home, and a couple of others have got certified as per that as well. So that is something which has got launched and is working now. It's run by QI now. And from insurance perspective, I believe that time has come for insurance to start looking at very seriously. I was saying chemotherapy at home, a lot of insurance companies are looking at adding in their portfolio of services. And now as home care becomes a lot more central in terms of healthcare services, hopefully insurance will consider with a lot more focus, maybe next 6 to 9 months. We are very hopeful.
Okay, so we had a question, do home care agencies have any national board accrediting them? And you've just said yes to that, right, Vaibhav? If you could just say the name once again, then our attendee could hear that.
QAI is basically the institute which has created the standards. And QAI says the way you have ISO or the way you have CICMM level 5, like that, there's an accreditation which QAI gives actually. QAI.
QAI, okay. We have one from Mr. Padmanabhan. Home care is emerging as an organized sector, but resources are hard to find, and also there are no standard training protocol. How is the industry looking to address this? Hello?
Yeah, I can.
Hi. Did you get, anybody wants to take that question? Sorry, I never said. I'm opening it up to all the panelists. Who wants to take that? Dr. Rana?
You see, it is a fact that there's a severe scarcity of trained personnel, but I think it is also very important to understand that apart from technical training, the attitude of service or caring is also something that is required for people who provide the last mile care. And that is something that is not something that you can train them into understanding. The technical aspects of it, there is NSDC and other skilling bodies have been working at it, but unfortunately the end products are not necessarily great because once you get something for free, you don't really put your mind to it. We found that very often that people who have got this free trainings have really not made the most of them. So I think the training has to carry on. After you have engaged somebody, the on-job training becomes very, very important. And maybe, I don't know, it would be good to have ability to find the right kind of people and then skill them up while they move up the rung of complicated cases that they can deal with.
Mhm.
You know,
Okay,
you cannot get ready-made stuff.
Dr. Mukherjee. The next question is from Colonel Sridharan. We understand that care is expensive. However, there's a perception that home caregivers from reputed operators providing home care for different types of care requirements are expensive. How wrong or correct is this perception? And in the current environment, will the cost go up? And if so, by how much? Rajgopal, if you'd like to take that question, please.
Absolutely, I would. Thank you, Moni. It is very true that currently, if you look at the kind of cost structures that companies are running with, especially the organized players, I think at the end of the day, they are recovered from the consumers. Okay, and there is a very general feeling in the market that the home care services cost, the services pricing are pretty expensive. Okay, and we have realized that firsthand because see, these costs are not recovered by insurance at this point in time. They are all out-of-pocket expenses for a family. Okay, I come from a healthcare background, and there's a very good saying that a couple, if they have to take a decision between spending for the child and their parent, they would actually spend for the child, not for the parent. Actually, okay. So given the fact that it's an out-of-pocket expenses and it's not currently covered by insurance, I think the providers have to keep the end price in mind. Absolutely. In fact, we are trying to work hard on that to see how they can achieve. The one way of achieving that is to keep your cost under control. If you're going to be absolutely top heavy, I think that's going to be a disaster at this point in time. And also, how much can you spend on the marketing spend, etc. All this goes back to loading onto your consumer pricing. So my view is, I think currently the home care services are expensive. I'm talking about the mainline services, not the sub services. And I think providers have to take a deeper look, considering the fact that insurance is still far away from us.
The next question is, Vaibhav, that's for you from Rima Nade. How do you manage emergencies at home in case of interventional treatment being managed at home? Example, chemotherapy.
So when we do chemotherapy, of course, the way chemotherapy works today is that first couple of sessions always happen in the hospital. And so we get the full understanding of what are the possibilities of this working or not working. And post that, only after understanding the patient condition fully is when the chemotherapy happens at the home. And all the precautions which are taken in the hospital are taken at home also. And in case of any emergency, of course, given that we have seen the patient situation and a couple of sessions have happened in the hospital. If at all anything has to happen, basically it will get managed the same way it get managed in the hospital. The patient is taken back to the treating doctor and the hospital immediately. But it always gets followed by a couple of sessions in hospital, so we know exactly whether the patient is fit to be doing chemotherapy at home or not.
Okay. Thanks, Vaibhav. The next question is for Neha. Is it possible to manage a dementia patient with the help of family members and a care plan full of engagement at home? Hi, Neha, did you get that? Oh, I think she's dropped out.
Neha, yeah.
I think we've lost Neha. Okay, we can go to the next question then. Are there home care courses available which body provides? Okay, accreditation we've talked about, but are there any home care courses available in the country?
Not as of now, which we are aware of actually, sir.
Yeah, the problem is that all the courses that are available are generally general duty assistant courses. Specifically, home care is something that is required but is not actually available.
The next question is from Sri Kumar. How do you handle emotional connect of patients to home care assistance in terms of service continuity? Who wants to take this question? Mandeep?
Yes, I can take on. So emotional connectivity is very, very important when it comes to improvement in the health of the patient. So caregiver, as Dr. Rana had also mentioned, that caregiver doesn't necessarily be absolutely professional about the job. Of course, the job should be done well, but emotionally he should be connected and he should know how to handle the patient. He should be more patient, as in more compassionate towards the patient, towards the elder. So these are the small little things which are required for assisted daily living. And it is very important for the families also to look after the carer, because after all, 12 hours of service or even 10 hours of such service, which is completely monotonous, very monotonous, because an elderly, if he's bedridden completely, he'll be absolutely lying down. A little bit of engagement here and there, which would happen once in an hour or once in 2 hours. Beyond that, over and above, there is nothing for the carer as well, who's a young boy or a young girl. So the family should be very, very emotionally compassionate, equally towards the carer, as the carer should be towards the family. So if this kind of a bonding is formed, then it is very easy to continue the service.
So would you say that there is scope for, for home healthcare providers to even train the families in how to look after the people who come into the homes? Because quite often we don't.
Yes. Very, very important. You should not consider that this guy has just come to look after my father and let him keep sitting. In fact, at times they are ill-treated as well. So we need to actually go and counsel the families as well, that please don't ill-treat them. Be compassionate towards them if you want your father to be.
And maybe that should go into a guideline book as well. How do you look after the people who come? And Vaibhav, this last question is from our side to you. Would you say that using home health and telemedicine to keep patients treated and away from hospitals is the right thing to do, and that in the post-COVID-19 world, I don't think there's a post-world, but ongoing world, there will be more focus on home healthcare?
I think by all means, I believe the time of home healthcare has come. I think all of us on this panel have been working in this field for quite some time. And if you are looking for one inflection point, I think this is the inflection point. And as you rightly said, telemedicine is here to stay. We have been talking about it again, and the legal opinion and other things on that were not very clear, which government has taken extra pains to clarify at this time. Yeah. Not only us, I think a lot of other players, all the hospitals are offering teleconsulting right now to the patients, because patients not walking into hospitals, especially elderly and people with other vulnerabilities, other comorbidities, is a reality we all have to adjust to. And teleconsulting will grow in numbers, not only in big cities, also basically connecting to tier 2, tier 3 cities, and offering this as a strong, critical way of delivering healthcare will become very, very prominent now, actually. So we believe telemedicine is here to stay and grow.
Thank you. Neha, there was a question for you, and I had asked that. So if I will just, we have 2 minutes over, but if you can quickly tell us, is it possible to manage a dementia patient with the help of family members and a care plan which has engagements in it, various type of engagement? Is Neha there?
I don't think Neha is there, actually. Can I take this on, please?
Yeah, take it on. Go, please.
Oh, Neha is talking. Yeah, go ahead.
No? Neha, you're muted. She's not there.
Yeah.
Dr. Mukherjee.
Yeah, we do a fair amount of dementia care as well. We work with ARDSI, which is an all India body for Alzheimer's and related disease. And we get our caregivers trained by them. What we have found is that the best caregivers undoubtedly are the family members in terms of their intent. But in terms of how they execute it, they are not necessarily the best, because they have emotional angles which are not necessarily the best. So training the family members in understanding dementia. I think dementia is a very misunderstood condition. And it is not only about memory, it is also about their cognition loss. So the fact that somebody doesn't understand is not because the person is being unmindful or is playing the truant, but this is a part of the condition. And first, making the family members aware, then there are certain strategies that can be taken when people get angry or frustrated, the patients. And the ability to deviate from that topic, not to continue to quarrel or to argue, but to deviate from that, make the person think about something else, related to their past, to pleasant memories in their past. So there are ways and means which are fairly simple, but which needs to be taught to the family members and maybe reiterated. It's not something that comes naturally. My mother is 78-year-old, and I have to admit that even with providing care to a lot of people outside, I can't say that I deal with her to the best of my ability. I'm sorry. So it needs something that needs to be reiterated.
And this is a last question I'm taking because we are like 4 minutes. And this is a very interesting question, and therefore we will take it. It's from Dr. Rekha Khandelwal. Sometimes the elderly are all alone at home and children are out of the country. If they need home care and there is no one to look after the maintenance of the house, is there a need of elder care center which can provide basic medical care and home care, which is provided by home care players? So she's talking about a confluence of home care and medical care. I mean, home health care and home care.
So I can take that question, and
okay, Raj.
Other panelists can jump in. See, we have been experiencing this. There are a lot of elderly people who live alone in their own homes. Okay, and so they are asset rich and cash poor categories. Actually, we see, and there's no one to actually work with them and help them through many of the maintenance issues, especially relating to food. In fact, during the COVID-19, the biggest challenge that we had is questions from folks saying, "Can you provide food for us at home?" And of course, that was managed. Okay. So step-down facilities offer a fantastic alternative for this, especially during the times when they need a continuous care or attention. Rather than providing that at home, I think it's important to move them to a center which is more safer and where there is peace of mind for the children and the family and the spouse, etc. So I think this question has been coming up, and to answer the question much more differently is that some agencies are actually trying to blend these maintenance care along with the medical care. And there are a lot of offshoots that are happening. As we can see in our own ASLI organization, we have a few members who are doing this. I see a future for these organizations and certainly a good proposition to be in.
Moni, our elder care is all about that. We do cater to every requirement of an elder, be it healthcare, be it engagement, be it safety, security.
And home services,
yes,
as in cooking, cleaning, etc.
So all this is a part of a game. So our veterans are the one point of contact for an elder. Any kind of a requirement, they call up our care and coordination center. Everything is monitored by these ex-service personnel. So the discipline is maintained. There is nobody who misbehaves with an elder. So everything is taken care of. So this is all about elder care.
Thanks, Dr. Any other suggestions from the panel? Otherwise, we are going to close now because we've overshot the time limit. So thank you everybody for being with us today, and thank you to our attendees. Thank you very much.
Thanks a lot. Thank you.
Thank you. Bye-bye.
Thank you so much.